Hi, everybody. Welcome to the last webinar in our series for this calendar year. We have been enjoying this series of webinars throughout the year. And really the aim of these webinars is to give you as much information as we possibly can on particular topics. And the one that we're going to speak about today is star ratings and aged care reform. But before I do that, I'd like to begin by acknowledging the traditional custodians of the land on which we gather today and to pay my respects to their elders past and present. Where we are today, that is the Gadigal people of the Eora Nation. But I'd also like to acknowledge the elders past and present across Australia, wherever you are on the webinar today. I extend that respect, of course, to all Aboriginal and Torres Strait Islanders peoples on this call. So welcome, and thank you all for taking the time out of your very busy schedules to be here today. And I know that the year's running out rapidly. We're in December, a couple of weeks probably for most people, and there's a few things still left to do. But the focus of the webinar today is really on having a look forward. There's a number of changes coming in the next 9 to 12 months, consultation and actual delivery of some key changes. And so we're going to be talking about a number of those today. We're really talking about them in two key buckets. Ones that really focus on sort of the commercial side and funding around the QFR, the star ratings, and the accommodation payment review. That's all happening now or in the next 6 or 9 months. And then the quality and governance side. So there's new legislation. There's definitely new quality indicators starting to be collected in April, and new quality standards. And those new quality standards are going to create a significant amount of change because they're so important to everything we do right across the organisation today. And so changing them even slightly it creates quite a ripple of work. So changing them significantly creates a lot of work. So I just wanted, before we get onto that, I just wanted to make note of a couple of things. First of all, we haven't got any providers on the panel today. We do this every now and then, the webinars. We just try to answer as many of your questions as possible. So we thought this last one in the year might be a great opportunity for you to ask all of the questions that that you've got. Unfortunately, we can't put people on air, so there's no point raising your hand or anything like that. Just put your questions in the chat, and either one of the consultants, Petra's there online, will try to answer your question directly, or we'll moderate those questions and we'll make time for them throughout the session and try to answer as many of those questions as we can. So please put your questions in the chat. The other point I wanted to make was that there's been two pieces of change that have gone in on the 1st of December. So there's the governance for boards, the new governance requirements, and the new code of conduct. And of course, the new code of conduct nominally affects every employee in the organisation. So we're not going to talk too much about that today, but we did write a blog in our last Mirror's mail. So we're going to pop that in the chat. So if you're interested in that new code of conduct and our views on it specifically, that'll be in the chat, and you can go and have a look at that and look at the rest of our website content and Mirror's mail. If you're not subscribed to that, please subscribe and get these updates all the time, every month. The other thing I wanted to do before we start is, before we talk about what's next and what's coming, I just wanted to have quickly just flag what's happening in the industry at the moment now that we've launched AN-ACC on the 1st of October. There's a very significant issue that is sitting with the industry at the moment, which is that the current average price, average funding for per resident is sitting several dollars below the 225 that the department has targeted. And before we all start complaining about underfunding, and we're not even saying that the industry's properly funded or not properly funded. That's something that we're all going to have to figure out over the next months, including the department. And we meet regularly with Mark Richardson and Nick Hartland. We met just the week before last with them and talked about a number of these things. But they do acknowledge that the current average is sitting under that $225, several dollars under that $225. But also, one of the big implications of that is that, as we predicted, when a funding model changes, typically the industry is not able to draw the correct level of funding out of the new mechanism, because it takes a while. There's a learning curve, and it takes a while for the industry really to understand what they need to be doing. One of the simplest things that you can be doing, of course, is reviewing all of your classifications. A lot of your classifications will be old, going back to the shadow assessment process, which could be well over a year old. And accuracy and the freshness of those classifications is really, really key. But what we're talking about here, and what we're going to be talking about a lot more in February, in the next webinar we do, which is in early February, is talking about this new target operating model for AN-ACC. And what that basically means is you need to be on top of the accuracy of your classifications. Whether you choose to put those reclassifications through or not, you need to know what the accurate classification of each resident should be. Obviously, deciding to reclassify something can change your care minute requirement, but that's not mandatory for us, but is a really important revenue side, both for admissions, which is changing your class mix, and for the reclassifications as residents' requirements change. So that's the revenue side. Then on the cost side, really the ability to execute an efficient roster, to know what that roster should be from a care minute requirement, to be able to execute that efficiently, minimizing the use of agency or the inefficient use of contracted hours, and really be able to tweak that, adjust that over time, and really bringing those two things together. So an efficient roster and understanding what you can actually execute at that facility in terms of a roster, and the class mix and the natural class mix, and the care minute implication of that class mix, and really letting those two things balance out over the next few months and bringing them together until you can work out, do I need more staff, or do I need to bring my classifications down to my care minute requirement, down to my roster? How am I going to bring those two things into sync, into equilibrium? And that's the target operating model everybody should be working towards. And if you don't understand that, or if you aren't making, and we haven't really seen anyone making good progress towards that. They are making progress, but we're well away from getting to where we need to be. That's an important note I wanted to make before we start talking about what's next. But without any further ado, let's get into talking about what we came in to talk about. And first of all, I'll throw over to Tyler to talk about the commercial and funding aspects of what's changing.
Yeah, thanks, Andrew. I've got a few topics that I'll discuss, and you'll have to forgive me if I have to inject some forced segues between the topics. But the first thing I'll touch on is the QFR report that providers are required to submit now on a quarterly basis, and it looks the structure of it is what you see on your screen here. So we're going to be providing that prudential data to look at how compliant a provider is with regard to permitted uses of capital that they're holding, financial data. So 70-80% of your revenue that comes from Medicare, and looking at really the viability of providers. But of course, now we are submitting some delivery of care time estimates, or actual delivered time data, and that will be really important for the department. And I guess what we did historically with the ACFR, the annual aged care financial report, it was a really significant undertaking for finance teams to get that compiled. And with the QFR, we're essentially quadrupling that effort required. And so I think what'll be important is building efficiencies in how we compile that data, because it's now really valuable to find those efficiencies. And so for your revenue data, where 70–80% of that is all contained in Medicare data, Mirus Metrics can provide that quarterly revenue at the click of a button. So anyone that's looking to build efficiencies in producing the QFR 4 times a year, please keep that in mind. But I guess I'll focus in on that labor costs and hours reporting, because that really is data that the Department of Health is going to rely on quite a bit. They're going to use that data, well, obviously to contribute to your star rating. So you'll have a care time star rating for each service, but it's also going to be used to inform costing studies for AN-ACC and the funding model that they've built around having a direct relationship between subsidy and a case mix, care minute requirement. And so that QFR data is the Department of Health's only resource to understand the care time being provided. And so it's extremely important for them and their capacity to form legislation. And a lot of that legislation that will govern a care minute requirement that we know will come into effect October next year still has to be drafted. So I think a lot of the language that they use to govern that is really going to be guided by what they can derive from that QFR data that's being submitted now. And with regard to that care time data that we put into a QFR, it obviously depends significantly on the definitions and the guidance that we get from the department with how we interpret any given shift that can be included or excluded from that data. And we've seen that guidance shift and those definitions change. And it was interesting that there was quite a significant change to the guidance the department was providing that came out shortly after that first QFR report was due. And so I think that is going to have a knock-on effect with subsequent QFR submissions, where I think that care hours reporting is going to be really significantly impacted. And what that will affect foremost is the star rating for that outcome. And so if we jump to the next slide, we can get a bit more visibility of what that star rating looks like. So we do know that every service will have an overall star rating that is the calculation of 4 individual components that each have their own individual star rating. The most heavily weighted of those components is the consumer experience report. So at 33% of the total outcome for a star rating for any service is what our residents are saying about the service and their experience. But closely behind that is the service compliance at 30%. And I won't spend too much time on this point, because this is really what Katie will be discussing after I'm done, and really getting into the detail of what the compliance looks like across those standards. And I guess what I'll focus on is still that care minutes. So 22% of the overall rating, but a individual rating in and of itself is the care minutes being provided, and how that compares to the assessed case mix based on a claiming profile. And I think what we know from AN-ACC and the RVU, the relative value units that are associated with each classification, is that number is the minimum as it pertains to a mandate, and meeting that minimum is only a 3-star outcome. And so obviously if you dip below that, there will be further consequences beyond a lower star rating. And again, that's legislation that we're still looking for to come out of the department, and one that we suspect will be guided by that QFR data. But on the other end, how is it going to work for providers to add a service, increase a star rating beyond a 3-star? And on the next slide, there's a breakdown of the different combinations of ways that can be done. So it is a connection between RN specific time and overall care time. So RN being a subset of that total care time. And it is all dependent on what is claimed at a service. So your AN-ACC paid claims entitle you to a prescribed amount of subsidy based on that case mix. And that has a direct link to the care minute requirement. And what you can see, for example, a 5-star rating requires you to exceed your RN time by 25%. And then the total care time to be in excess of 115% to achieve that 5-star. And it gets even more complex in terms of how you can achieve a 4-star, where you can see the six different combinations of total time and RN time that would result in a 4-star outcome. But I think ultimately how this star rating and the how you resource a resident population really does impact the QFR data, or the viability of a service, because that direct relationship between subsidy and a care minute requirement means that our sustainability, our viability is hedged. We're pegged to a prescribed margin that can be achieved on subsidy dollars, and it's roughly around 75%, meaning that 75 cents of every subsidy dollar would go to a minimum roster cost. So every minute or hour of roster time that we put on top of a minimum care minute requirement reduces that optimal conceivable margin. And what really impacts the total roster the most is the multiplier that you put against a case mix number. So as Andrew mentioned, the data that we had leading up to AN-ACC going live was built around this assumption that the average care minute requirement across the industry would be 200 minutes. And we know now that the total claim profile of the industry is actually lower than that. So it's around 196 minutes. But at any individual service, whatever that outcome is, the number of residents that you multiply against that average is how you aggregate to a number of FTE or shifts required. And we are already seeing the number of residents entering facilities increase. And we attribute that largely to AN-ACC as well, in that historically ACC fees that resulted in very low subsidy outcomes would be not suitable to offer a place to, and that same resident that had a low ACC fee outcome will now have an AN-ACC outcome that provides significantly higher subsidy. And so providers or services that are in a position to reduce empty bed days are doing that at I guess rates that are turning that industry occupancy trend around. We've seen occupancy declining for 3 or 4 years, if not longer, where it was historically stable between 93 and 94%, where now it reached a low, in September of around 87%. And since October, we are seeing that industry occupancy trend starting to turn around. But again, the impact of that ultimately is that it increases our obligation of care, so that minimum roster gets quite large very rapidly as you start increasing that multiplier. And I think that in turn makes that operating result, increasingly important to monitor. And again, because it is such a finite margin, what providers really have to start looking at is how they supplement that revenue stream or that profitability. And the biggest component to how they do that is the next largest component of revenue, which is their accommodation payments. And so what I'll segue into now is what we are looking at next year is with regard to that accommodation payment review. With the announcement of AN-ACC 2 years ago, they put out a 5-year horizon for all of the reforms that were going to be visited throughout that time span, including drafting of an entirely new Aged Care Act. And so within those pillars on the horizon that are going to be visited, looking at how care recipients pay for their accommodation is going to be quite a major piece to that. And there's a few really key components that are going to be a part of that review. And they include the means tested care fee. So how do we assess the means and income of any individual and the outcome of that and what that means for their capacity and requirement to contribute to their accommodation. And closely aligned to that will be looking at the basic daily fee. So the department and Centrelink are really, I guess, sort of obliged to retain that 85% of a aged care pension figure, because it allows anyone who needs aged care services to have that within their financial feasibility. So a full pensioner is still able to afford that basic daily fee, but looking at how we can deregulate that in a way that where it would, maybe look something similar to additional services, where people that are willing or have the means to contribute more are doing that. And then the bigger component to that review is looking at how RAD and DAP arrangements are structured. So an entire structural reform of how accommodation is paid, because we can see in a lot of our data that the current structure is not that feasible. We're not getting enough out of that to offset the cost for what it's meant to be funding. And so we know that all of that will come under review, but we don't want to go about speculating what any of those outcomes will look like. But one of the things that the department has already talked about is how within means testing, the way the primary residents can be protected. So things like including the full value of an owner's home as compared to what it would be now, capped at quite a nominal figure when you compare it to sort of median home prices around the country. And I think one of the things that we need to look at is really that accommodation payment, and what would be the impact of adjusting it to reduce that protection for a primary residence, but really reducing the benefit of paying a large lump sum RAD, where a cash rental structure will actually benefit the industry to quite a large extent. I guess the way Living Longer, Living Better was structured in 2014, was looking at how do we put a large amount of capital in providers' hands to help them build a infrastructure that would support the coming demand of a very large aging population. So a baby boomer lump of population moving through our age brackets and reaching a demographic that is one that's going to need aged care services, where that infrastructure is largely built now. And so the need for that large amount of capital on hand is greatly reduced. And the liability that is held by the Treasury in underwriting all of that capital and ensuring that it can be refunded is a liability that they don't necessarily want to have at such large numbers when the infrastructure that it's meant to support is already in place. And so if we jump down to the next slide, we can see a chart that sort of describes the trend that has occurred historically back to 2016, looking at the outcome in terms of accommodation revenue from a RAD in terms of dollars per bed per day. And so it's sort of describing that missed opportunity cost in holding a lump sum. So you're relying on an interest rate to produce that revenue, where what we really want is a rental style payment. And you can see the results of those RADs in the financial year just ending last June, and then adjusted for the consideration that there would be a equivalent rental amount payment paid on different RAD averages. So the industry average currently is around 450,000. And that's another area that we can really seek to be reviewed, is that maximum of 550,000, where maybe deregulating that maximum price could trigger some impact as well. And I guess one of the things that we see from demographic analysis is that people that are entering or already in aged care recipient age brackets, that group of the population is now wealthier than it has ever been before in history. And I think what's sort of important to note with that is that these adults and every adult really at every stage of their life has to be financially responsible for their housing. And I guess the question is, why should it be any different for adults that are receiving residential aged care? And one of the things that is really beneficial to this more affluent group is that the groups are individuals that have the means to pay a full RAD are contributing less than those who are paying the equivalent DAP. And so I think, again, reviewing how we make it more attractive to pay a daily rental style payment than making it so beneficial for those who can that pay a RAD. So seeking a rental component from the RAD contribution, and that ultimately offsetting that loss of potential interest earned by a consumer through paying that full lump sum, gives you quite a direct impact in terms of the cash flow for any given service. And so that being said, there's a lot of sort of financial calculation that goes into it, but ultimately what we know will happen is a review of that mechanism and likely change. And one of the things that we've seen as a MO for Medicare and the Department of Health for the better part of a decade now is seeking for care recipients to contribute more to their care regardless of the care setting, when they have the means to do so. And so that's all I'll say with regard to that accommodation review, and just end by saying that it will likely look different in the future.
Yeah, thanks, Tyler. Yeah, lots of interesting information. And I think this particular aspect of the changes in the next 12 months is really is the other half of the funding reform. Once you've constrained funding opportunities through AN-ACC with external assessment and care minute requirements, I imagine that opening up or creating a little bit more freedom in the accommodation side makes sense to allow organisations to be a little bit more commercial about what they're offering, and to maybe make some more money from that side rather than on the taxpayer funded care side. So thanks for that. Let's just quickly hop over to Petra and just see if there's any questions that's come up in the chat. Petra?
Yeah, so there was a question on the 15% wage rise decision by the Fair Work Commission, and how that will be delivered, and if there are, I guess, any caveats that providers should consider based on that decision.
Yeah, I think the key element there is that most people are talking about is on costs. So one thing is the 15%, and I think the government has repeatedly said that they will pass that through, so they will fund that. I think there is a question about the mechanism of doing that too. It's not just about adding it onto AN-ACC or a supplement. How do you get it through to the residents, to the staff themselves? But really, on cost seems to be the one that's creating the most debate, and that's the one that we're waiting for clarification on, which was supposed to come out at the end of this year. So they're running out of time to do that. But yeah, obviously, when you add 20% on costs onto 15%, that's a few percent of margin that no provider can really afford. So yeah, we'll wait to see whether that is clarified when they make the statement about how they're going to fund it and what the mechanism is.
And one more question for Tyler on RAD balances. So where providers have used RADs to invest in capital and other projects, or are operating at a loss and have depleted cash reserves, how will that impact them?
Yeah, it's a really interesting question, because we know from 2014, we saw a lot of newer providers really leverage that RAD holding to offset loans, build infrastructure, where I guess larger and more established providers already had that treasure chest, and so they were able to seek DAP equivalents to get cash flow. But yeah, ultimately we do have a group of providers that would be leveraged to the point where if the legislation turned on a dime, they wouldn't have the assets to refund that, unless they're relying on RADs coming in to replace those that are departing. And I think the only feasible solution is really a staged approach, where the legislation can't rip the rug out from under those providers. It will have to be a gradual shift. And I think the other reason that we really have to, or Canberra particularly has to be quite careful with how they assess means and how they treat that primary residence, because I think there is some stress testing that looks at if the full value of a primary residence is included, it obviously then makes that asset a lot more expensive to hold on to. And the impact of that could be that a lot of people that are seeking to fund larger lump sums are more compelled to liquidate that primary residence. And if that happens in a large wave, it can really significantly soften the real estate market, which could be in effect very very troublesome to the economy as a whole. And so all of these considerations are things that have to be accounted for. But ultimately, the sustainability of the sector is what is at risk. And so it will be potentially something that is a bit onerous to look at and get your head around when we do see that new structure of how accommodation will be funded. But it will be one that I think seeks to address all of those concerns. So providers that are highly leveraged need to continue taking in large lump sums, but at the same time, how can we encourage our care recipients to contribute that lump sum while also paying a cash rental on top of that? And yeah, I think there will be a lot of financial consideration that goes into that, but yeah, multiple factors at play that all need to be considered for sure.
Yeah, thanks, Tyler. Let's keep moving along. Katie.
Thank you, Andrew. So as you're all aware, there's been a lot happening in the legislation space for aged care. On the 1st of July 2021, the Aged Care and Other Legislation Amendment, the Royal Commission Response No. 1 Act came into effect. And then on the 27th of July this year, 2 new pieces of legislation were brought in. So that was the Aged Care and Other Legislation Amendment, the Royal Commission Response Act of 2022, and then the Aged Care Amendment, Implementing Care Reform Act 2022. So the first piece of legislation that was brought in really looked at implementing responses. I think there were 17 in total that were made by the Royal Commission. And so that included things like the new funding model, so AN-ACC, the star rating systems that we've just been speaking about, the new code of conduct, which was recently released, expanding the SEARS reporting program into home care and flexible care, and then also strengthening governance across the sector. It also introduced legislation around improved information sharing between aged care, veterans care, disability care. It revised the restrictive practice arrangements that we currently have, and it expanded the functions and renamed the Independent Health and Aged Care Pricing Authority. So quite a big piece of legislation there for us to get our heads around. And then the second piece was really looking at improving the integrity and accountability. It banned the exit fees and enabled capping for administrative and management changes in home care. And it also enforced the government's policy or commitments around having registered nurses in residential aged care facilities 24/7. So that'll commence the 1st of July 2023. And of course also introduced mandatory reporting requirements. So in addition to this, work has begun on the new Aged Care Act. There will be public consultation around this, so you can get involved in that. Updates we put on to will available to the public to have a look at and engage in through the Aged Care Hub. So you can just do a quick Google search on that and should be able to find nice, easy directions to engage. So on that note, let's have a look at the quality indicators. So there's been some changes in this space as well. So I'm sure you all know. So the current quality indicators that we report on came into effect on the 1st of July 2019. And that required us to report on things like pressure injuries, physical restraint, unplanned weight loss, falls and major injury, and medication management. So from the 21st of April next year, we'll also be required to report on activities of daily living, incontinence care, hospitalisation, workforce, consumer experience, and quality of life. So part of the information that's been shared is that there'll be additional tools that providers will need to use to measure these things. So if you don't already have these tools in place, drafts are available in the draft Quality Indicator Manual Part A, so that's version 3. And those tools include the Barthel Index for ADL, so that's a tool that's been around for some time. Not all homes currently use that as part of their clinical framework, but something to consider moving forward, seeing as we'll have to use that as part of our measurement tool. And then there's the Ghent Global Incontinence Associated Dementia Categorization tool, which again, probably not widely used, but we will have to get our heads around those tools. And then they also introduced the Quality Care Experience Aged Care Consumer Assessment tool and the Quality of Life Care Consumer Assessment tool. So providers will need to think moving forward whether they want to integrate those tools into their clinical frameworks. And if they do, when will they do it? And then also think about what benefits they'll get out of integrating them or not integrating them, whether you keep them separate from your clinical framework and use it as a auditing or measurable tool, or if you'd like to integrate the findings to make sure everything's nice and consistent across the way that we're delivering care. We might pop on to the next slide and cover off the standards, because that's quite a big topic that's happening at the moment. So a little bit of background. In March 2021, the government announced that they needed to do an urgent review of the quality standards, and that was in response, of course, to the Royal Commission. So the intent behind the review was that they'd have some focus areas, and that was around governance, diversity, dementia care, food and nutrition, and clinical care. And then the Department of Health and Aged Care decided that they would work in conjunction with other departments, so the Quality and Safety Commission, along with the Australian Quality on Safety and Quality in Healthcare Commission. So together, they undertook a review of the standards and devised the standards that you can now see on your screen. So there's now 7 in total, or there will be 7 when these come into effect. So condensing a lot of the focus areas that we have in the current standards, moving them into 7 sort of centralised areas. With standards 1 to 4 applying to all providers, and then standards 5 to 7 only applying to providers who deliver those services. So it segregates it a little bit and makes it a little bit more clear and simple for people to understand. Each of the standards has the same layout. So each standard has an expectation standard for the older person, outcome statements, and then actions, which are what providers will be used to be measured against to gauge compliance. So as part of this review, there has been some public consultation, and that took place between the 17th of October and the 25th of November. And that was done through some focus groups, surveys, written responses. That, of course, now has closed. And the next stage will be that there'll be a pilot planned for early next year. Following that pilot, they'll do an evaluation of how easy the system was to integrate into residential aged care and home care. And then, of course, it'll move across to be legislated and put in place. Timeline on that is unclear, but probably expect it to be, 12 to 24 months away. So as part of this redevelopment for the quality standards, the ACSQHC, it's a long acronym, assumed responsibility for looking at clinical components. And they've looked at that since they were engaged the 1st of July 2021. So their review included looking at oral health care, medication management, pressure injury prevention, wound care management, continence management, falls prevention and mobility, and of course, infection control. And then there was an independent evaluation undertaken by KPMG. So that independent review looked at the clarity of the wording and the intent of the quality standards. And then, of course, the relevance of the quality standards to each aged care service, whether they are achievable and measurable, and the impact that their quality standards would have on older people, providers, and key stakeholders. So if we flick to the next slide, we've broken down the standards so that we can see where the key changes are. So standard 1, similar to the current standards, is really about the person. So it's got retained concepts that we currently have, things like treating people with respect and dignity, valuing individual culture and diversity, respect for privacy, of course, and then current and accurate timely information is also retained in there. And they've strengthened focus through the actions around person-centred care. And so what that really means is truly understanding a person at an individual level. There's lots of focus around that in these revised standards. And then also providing culturally safe care, and what that means to each person will be different. And so providers need to have a really good understanding of what that means for each person as an individual. New concepts that have been introduced are around trauma-aware care and healing that is culturally safe. I think this is a great initiative, as a lot of people who are coming into care or receiving home care for the first time, for example, have gone through some type of trauma, or they have throughout their life. So it's important that we acknowledge those traumas and that we put supports in place where consumers would like them, to make sure that they're able to live the best life that they can. And then, of course, there's things around decision-making and dignity of risk. So making sure that we're enabling people to take risks where they want to, and particularly around focusing on promoting independence, even when there's risk involved. So standard 2 draws on standards 6, 7 and 8 from the current standards. So this one is really about the organisation, and it's retaining the concepts of supporting older people to make complaints and responding to them appropriately, retains the concepts around open disclosure and worker competency training support and monitoring of workforce performance. That's really quite important in this one. And then it's strengthening areas of focus around partnering with older people to inform care and services. There's a few requirements under this standard, the organisation, where it really defines having, older people or consumers engaged in strategic planning, for example. So making sure that everything's sort of focused and we're getting a really good understanding of what people want, who we're providing care for. So something to think about, providers can start implementing strategies around that now, which will help as we start to transition to these revised standards. The other things that it covers is around quality and safety culture, accountability and quality systems, workforce planning, and of course, emergency and disaster management. Throughout these standards, the term systems is used quite frequently. So it'll be really important that providers have a firm understanding of what their systems are, and that they're well defined, and that they're tried and tested and they're working. The evaluation process will also be really important in demonstrating compliance. And then we go to standard 3. So that's around care and services. So this standard draws a lot from standard 2, 3 and 4 of the current standards. It retains the concepts around assessment and care planning, but it does require us to have more detailed information. So it's really about that comprehensive assessment and planning process, and partnering with consumers to make sure that we, as I said earlier, really understand them, and that aligns nicely with the revised standard 1. It will strengthen concepts and focus around delivering care and services in a way that supports independence and quality of life. So again, that brings in that risk factor thing that we need to manage where applicable, and putting things and services in place so that people can remain as independent as possible. And then also supporting people living with dementia. There's some great grant opportunities at the moment that are available. You can have a quick look on the website around, good initiatives in supporting carers for people caring with dementia at home and offering respite programs. And so that'll continue to be a focus as we move forward towards these revised quality standards. We also need to make sure that we're communicating regarding older people's care and services. So that's both internally and externally, where you have multiple providers caring for an individual. We to ensure continuity of care, there needs to be transparency and information sharing. And so that's something that providers will need to have a think about. How are we going to do this more effectively if we're not already doing it effectively? And then standard 4 is about the environment. So this one draws on standard 5 along with parts of standard 3 from the current standards. And it's really just around ensuring safe and clean, well-maintained environments. And that includes environments at people's homes for home care providers, and making sure that they're safe for both the person that's being cared for and for the workforce. It also touches on making sure that equipment is fit for purpose and all of those bits and pieces around safety in the environment. It'll also strengthen requirements or focus around infection prevention and control. So something we should be quite good at in the industry at the moment, and just a nice heightened focus on that, and some nice actions that go with it to make sure that we're able to demonstrate and measure accurately. Okay, so the remaining standards here, standards 5 to 7, as I said earlier, are only applicable to service providers who deliver these services. So standard 5, being clinical care, is drawing on standards 2, 3 and 8 of the current quality standards. When we were doing the public consultation for this particular standard, in the focus group, there was lots of discussion about this and how it's laid out. It's quite a lengthy standard. It is well defined, in my opinion. But of course, you know, there's always opportunity for improvement. So the feedback that was provided will be taken away and reviewed, and then any changes that are fit for purpose obviously will be implemented into the revised version of these standards. So standard 5 is really retaining those concepts around delivering care that's in line with a person's assessed needs, goals and preferences. Implementing, of course, a clinical framework, that's super important. Antimicrobial stewardship, and then maximising dignity for older people nearing the end of life. And then it's going to strengthen focus on use of digital clinical information systems. So there's some really lovely talk around integrating with My Health records, something which we haven't seen in aged care before, or so much before. So there's good opportunity for care management systems to get those integrations underway, so that we have that continuity in care between service providers. And then it will also look at medication safety, of course. One of the biggest things that we focus on in aged care, and of course reducing specific clinical risks. So this is where it sort of goes into things like you know, people who have falls, continence management, wounds, etc. like that. So that's actually quite defined in the actions of these standards and the outcomes. Next, we'll look at standard 6. So standard 6 is around food and nutrition. During the consultation process, there was a little bit of feedback that actions around hydration weren't necessarily clear. So, of course, that lovely feedback has gone back, and there should be a little bit of a revision around that just to make it a little bit clearer for providers. But essentially, this standard will be looking at how providers partner with older people to ensure that they've got quality food services in place, looking at that assessment of nutritional needs and preferences, and really defining that for each person. And then, of course, food and provision for drink, including menu design, choice and flavourful meals will be important, and that dining experience or the culinary experience. Standard 7, so our final one, which is the residential community. This one draws on standards 3 and 4 of the current quality standards, and it retains the concepts of ensuring that we are providing environments that enable people to participate in activities that promote and support their emotional, spiritual and psychological well-being, and that they have social and personal relationships. And it strengthens focus around minimising boredom, supporting people to contribute to their community if and when they want to, protecting the psychological safety of people in our care or who we care for, and transitioning people to and from the service. So that's really about, again, that information sharing, making sure that when we're transitioning people between residential care to hospital or home care into residential care, that those transitions are seamless and that there's a good amount of information shared so that we can provide continuous and uninterrupted care to get better care outcomes. And then, of course, connections with specialist dementia care services. So a heightened focus on how we provide care, promote independence to people who are living with dementia. Okay, so a lot of work to be undertaken by providers in this space. The good news is that we're on the forefront. We've got information early. We've got a guidance as to where the standards will be heading. So they're probably, I know we've got a lot on our plate in the industry, but it'd be good to, get a firm understanding of what these standards are and the things and the systems that you currently have in place that will support meeting these standards, and then identify where the gaps are so that you can start to put systems and processes in place to make sure that you can, that you're striving towards meeting the actions of these standards. Okay, thanks, Andrew.
Yeah, thanks, Katie. That was great. I learned a number of things, and I've heard this a few times. So, lots of work to do. Hopefully, that has been very useful for everybody. In terms of questions from the chat, I just had a quick chat to Petra. She's been responding to a lot of the questions that are in the chat. So maybe not so many that we need to voice here. I just wanted to let everybody know, though, that all of this content, all these questions, everything that you ask us goes in to feed our Mirrors mails. So we put the bulletins we put out the first week of every month. So please subscribe to that. Get onto our website and subscribe, and you'll be kept up to date with all of the information. I did want to flag that we do have a quality risk and compliance practice that's led by Katie. So I think one of the key messages from us is that the way to deal with this level of change, and I know it's daunting, and it's more change and faster change, and the government's very committed to their timelines, more so than they've ever been before. The best way to deal with it is to be aware. So to come to webinars like this, and I know there's a lot of webinars going on, but come to webinars like this and be well informed and start thinking about it early. That's a bit of change management transformation consultant for 20 plus years, and the secret is to think about it early and to start making moves early. And like Katie was saying, there's new assessment tools, there's adaptations to your clinical governance frameworks and strategies you need to do because of AN-ACC, and then there's these new quality indicators, and and then the new standards. So there's lots of reasons why, if you're informed, you can start making moves in the right direction once, instead of doing it several times over and over. So and all of this will be harmonized and synchronized to some extent, we think, within the legislation. And pretty much most of the change for aged care, at least residential aged care and home care, residential aged care will have been done. They've done funding, they've done the standards, they've done quality indicators, they've done reporting. There's so many aspects to aged care where this reform and accommodation review, that'll largely now be done. They've obviously got a fairly significant piece of review to do with home care in funding, and a lot of people would be happy to see something like AN-ACC go into that, go into home care, even if it's only so that there's one system across both, so you don't have to be operating two different systems. And I think certainly the model is driving a lot of residential aged care providers to be in home care as well. So that would make a lot of good sense. So I guess in the minute we've got left, I just wanted to a quick ad for the next webinar, which is on the 9th of February. We'll give everybody a good January off to consolidate. We'll definitely be publishing information in January, a review of 2022 and some of the more popular articles you might have missed. and then back into these webinar series in February. And what we really want to talk about is what I talked about at the start of the conversation about really getting that target operating model working and getting in the balance between your accurate funding and really efficient rosters, because that's where your margin is, certainly on the fairly significant proportion of your income, which is around your care funding. So please join us for that. On that note, 1 o'clock on the dot, thank you so much for joining us again. Thank you for all those people who have joined us month on month for these webinar series. We really are just trying to give back to the industry and shed as much light on as many things as we possibly can. Please let us know in the chat anything that we can do better. Please reach out to marketing@mirrors.group to comment on anything or make any suggestions about anything else that we can cover that you think you'd be useful, and reach out to us if you need help in any way. Thanks to Tyler and Katie for presenting today. And we wish you a great holiday period. Hope you all get a chance to do a little bit of relaxing. It's been a heck of a year, 18 months, 2 years, 3 years. So we've definitely been on that journey with you, and we're quite exhausted. So looking forward to a little bit of downtime, and I hope to see as many of you as possible back on the webinar next year. So take care, and thanks again for joining.